Hello, my name is James Ripa. I am Vice President of Business Development for Medical Reimbursement, Inc. I'd personally like to thank you for attending our webinar today. I would like to introduce today's speaker. Her name is Jeannie Dean. She is Director of Client Services and Coding for Medical Reimbursement, Inc. She directs MRI's coding department, compliance, and physician education. She is widely considered as the authoritative and expert source on coding services related to numerous healthcare payment systems, statistical reporting, and health research services for MRI's large academic and private physician practices. She has over 20 years' experience in the health information management field, including consulting, teaching, technical and management. Her experience had allowed her to provide coding, compliance, physician documentation, and revenue cycle management services to various specialty physician practice management organizations and private practices across the United States.
E&M coding documentation guidelines. This presentation today is going to focus on emergency department, and it will be based on 95 guidelines. The emergency room guidelines require you to meet 3 of 3 components to reach a level of service. The 3 components are history, exam, medical decision making. The history consists of present illness, review of systems, past family and social history. The exam is the number of body areas and organ systems, and medical decision making would be 2 of the 3 from the medical decision making table, which includes problem, test, and severity. The history of the present illness must be documented by the physician. The HPI is a chronological description of the development of the patient's present illness from the first sign and/or symptom, or from the previous encounter to the present. The HPI is distinguished by the amount of detail needed to accurately characterize the clinical problem or problems. There are 2 types of HPI. A brief HPI, which consists of 1 to 3 elements, and an extended HPI, which consists of at least 4 elements, or the status of at least 3 chronic or inactive conditions. The HPI would be things such as location, which is where on the body are the signs and symptoms, timing, when did the symptoms start or when did you start experiencing them, modifying factor, what gives you relief or makes it worse, quality is simply an adjective to identify the type of signs or symptoms, associated signs and symptoms, severity describes the pain, duration, how long have the signs and symptoms been there, and context is simply where or what was the patient doing when they first experienced them. The review of systems is an inventory of the body systems obtained through a series of questions seeking to identify signs and/or symptoms which the patient may be experiencing. The review of systems helps define the problem, clarify the different diagnoses, identify needed testing, and serves as a baseline for the physician. A problem-pertinent review of systems consists of systems related to the chief complaint. An extended review of systems consists of 2 to 9 body systems, and a complete review of systems consists of at least 10 organ systems. Documenting any pertinent positives and negatives combined with the statement, all other systems reviewed and are negative, will be considered a complete review of systems. Remember, when you use the statement, all other systems reviewed and are negative, that means the physician has checked all systems. You will need to check with your local carriers because some carriers will not accept that statement. Past family social history. The past medical history is a review of the patient's past experiences with illnesses, injuries, and treatments. Family history is a review of medical events in the patient's family. And social history is an age-appropriate review of past and current activities. A pertinent past family social history consists of 1 element. A complete past family social history consists of at least 1 element from at least 2 of the areas for the emergency department. There are 4 levels of E&M services based on examination. Problem focused is a limited exam of the affected body area or organ system, which is typically one body area or system, including the affected area, for a level 1 exam. Expanded problem focused is a limited exam of the affected body area or organ system and any 3 symptomatic or related areas or organ systems. This typically includes 2 to 4 body areas or systems, including the affected area, for a level 2 or level 3 exam. A detailed exam is an extended exam of the affected body area or organ system, and that's typically 5 to 7 body areas or systems, including the affected area, for a level 4 exam. A comprehensive exam is a general multi-system exam of 8 or more organ systems, including the affected area, for a level 5 exam. An exam cannot state cardiovascular normal. You must put any abnormal or positive findings, and you need to go into some detail. Remember, for a comprehensive exam, you cannot combine organ systems with body areas. A comprehensive exam can only be 8 or more organ systems. Medical decision making refers to the number of possible diagnoses and or the number of management options that must be considered, the amount and or complexity of the medical records, diagnostic tests, and or other information that must be obtained or reviewed, and the risk of the significant complications. The next few slides will show you the progression of the elements that are required for each level of medical decision making. Each of these elements will be described. Medical decision making has 3 categories. You have problem, which is the number of diagnoses or treatment options; test, which is the amount and or complexity of the data to be reviewed; and the severity of the problem, which is the management options selected. You must have 2 of the 3 columns that equal the same amount in points in order to determine your level of service. Always take the nature of the presenting problem into consideration when deciding your medical decision making. Remember, the medical decision making is basically the physician's thoughts on the care of the patient. This is the medical decision making table. You'll notice that the first and second columns have points under them. When using these 2 columns, you would add points to determine what level of medical decision making you can bill for. For instance, moderate complexity MDM requires 3 points, so you would need 3 points from at least 2 columns to be at a moderate level of medical decision making. If you have a patient with a new problem with no additional workup planned, and you order lab work and review old records, you would have a total of 3 points in the test column and a total of 3 points in the problem. See the following example. How to decide the medical decision making? You would simply take your table, and in this example you will see, even though all 3 columns have something highlighted in them, you only need to have 2 of the 3. Column 1, your problem column, in this example gives you a total of 3 points. Column 2, for test, give you a total of 1 point. Column 3, severity, is moderate, which is equal to 3 points. You can choose the 2 columns that have the same amount of the largest points, which would be column 1 and column 3. With this medical decision making, your level would be at a level 3 or level 4 for your MDM only. In this example, column 1, your problem, gives you a total of 4 points because you're planning additional workup. Additional workup can be things such as testing, EKGs, stress test, seeing orthopedic, being admitted. Column 2, for your test, you only need 4 points for a level 5 medical decision making. So if you ordered chest x-ray, labs, EKG, and you discuss the case with the family physician, you would have a total of 5 points. Column 3, your severity of problem, is moderate, which is 3 points. For example, you only gave the patient a prescription and told them to follow up with the family physician. In this example, you would choose to use columns 1 and 2 because these two columns both have 4 points. This would allow you to be at a level 5 for your medical decision making. The next few slides will go over some examples of each chart for each level. First example for level 1, we have a chief complaint, a brief HPI, problem pertinent review of systems, 1 past family social history, which gives us a problem-focused HPI. We have 1 body area in the exam, which gives us a problem-focused exam. We have straightforward decision-making, and if we look at our medical decision-making table, we can see that we have met all the requirements to bill a level 1. For a level 2, again, we have the chief complaint, a brief HPI, problem pertinent review of systems, 1 past family social history, which gives us an expanded problem-focused HPI. In the exam, we have 2 body areas, which gives us an expanded problem-focused exam, and we have low complexity medical decision making. Again, as you can see, we have everything we need for an expanded problem-focused HPI, expanded problem-focused exam, and low complexity medical decision making, which is equal for a level 2. On this patient, for example, let's say we had moderate decision making. We would still only be able to bill a level 2 because we only have 3 of the 3 components for a level 2 and not a level 3. Example of a level 3 chart. We have an expanded problem-focused HPI because we have a brief HPI, we have a problem-pertinent review of systems, and we have 1 past family social history. In the exam, we have an expanded problem-focused exam, and we have a moderate complexity medical decision making. So with all of those, we have 3 of the 3 requirements for a level 3. When you're billing a level 4 or a level 5, it gets a little more detailed. You have to have more things in your HPI and your exam and your medical decision making. So for a level 4, I'll kind of break this out to show you some things we need. A level 4, you need a detailed HPI, which requires 4 in the HPI, an extended review of systems, and a pertinent past family social history. So we have in our HPI location, which is the back pain. We have duration of 2 days. We have falling off the roof for modifying factors. And we have 9 out of 10 for severity. We have an extended review of systems. And we have at least 1 past family social history. The exam requires a detailed exam, which is typically 5 to 7 body areas. And you see we have constitutional and vitals, which is 1. We have back. We have skin. And we have HEENT. They've described the eyes, so that gives us a total of 2 points for that. We have cardiovascular and respiratory. We also have to have a moderate complexity medical decision making. On this patient, we ordered labs. We did an x-ray of the lower back, which was interpreted by the attending, and we gave the patient a prescription for Percocet. Again, we've met all the requirements for a level 4. A level 5 requires a comprehensive history, which again is an extended HPI, a complete review of systems, and at least 2 of the 3 of the past family social history. In this example, we can get the 4 that we need in our HPI from the first sentence, but we also have more in the HPI if we choose to use those. But sudden sharp chest pain for the past 2 hours, that gives us our 4 things that we need, or we could use pain comes and goes, numbness down the left arm, or pain is 10 out of 10. Our review of systems, we've reviewed the pertinent review of systems, and the physician has added the statement, all other systems reviewed and are negative. We have at least 2 of the 3 past family social histories. In the exam, we need 8 or more organ systems for a comprehensive exam. Again, you cannot combine organ systems with body areas when trying to bill a level 5 exam. The medical decision making must be high complexity. With this patient, you can see we did an EKG interpretation. We also did a chest x-ray, which was also interpreted by the attending. We ordered labs. We also discussed the case with cardiologist, and we told the patient they need to follow up for a stress test. With all of those, we've met all the requirements to bill level 5. Examples of critical care. You must take the entire chart into consideration. You want to make sure that we have pertinent information in the HPI, also in the review of systems, the past family social history. You also want to look over your exam. One of the main portions you're going to focus on most for critical care, 2 things. You're going to make sure the statement, I have spent the following amount of critical care time with this patient, excluding time spent performing separately billable procedures, and then the physician should include their time. But you also want to make for sure that this patient really was critical, so you would want to look over, again, the entire chart, the medical decision making. You could find key things like the patient was intubated, patient was in respiratory distress, and so forth. Proper documentation and the ability to prove medical necessity is now more important than ever. A recent letter from the Obama administration stated that over 55% of hospitals have qualified by the incentives offered by Congress to encourage healthcare providers to adopt and meaningfully use this technology used appropriately. EHRs have the potential to save money and lives. However, there are troubling indications that some providers are using this technology to game the system. False documentation is not just bad for patient care, it's also illegal. There are reports that some hospitals are using EHR records to facilitate upcoding of the intensity of care or severity of patients to increase reimbursement. The government's response to this letter: for every dollar the government spends on the RAC program, it yields $10 in return. Starting in 2012, the federal government launched the Medicaid RAC program. Some of the big audit companies are HMS, Optimum, Myers and Stafford. You can check your state's activity at the following website. Medicare RACs versus Medicaid RACs. A Medicare RAC audits are directed by CMS, where the Medicaid RAC audits will be directed on the state level. Medicare RAC vendors do not collect the overpayments or handle cash. With Medicaid RACs, the states must collect the overpayments from the provider and return the federal share of overpayments back to CMS. Medicare RACs have only one appeal system. The Medicaid RAC has an extra level of appeals. After the provider appeals the state can appeal to CMS. Further reasons why documentation is important. EHRs allow physicians to better document. There are many physicians and hospitals that believe EHRs do allow them to better document the care they are providing. Because of the better documentation, higher levels are being billed. They actually believe that before they may have been underbilling due to poor documentation. When used properly, EHRs can help prevent duplicate tests and remind the physicians about possible diagnoses and treatment plans not thought of before. Documentation is more important than ever because of cloning and copy and paste. Cloning and copy and paste is a big concern with EHRs. Documentation and medical records are being duplicated from one visit to another. Some fear this creates a significant compliance issue if the information copied negatively impacts the quality of care. Providers need to prevent any compliance issue by reviewing, checking, and being proactive with anything that is copied from a previous visit. EHR is viewed as an asset in care and payment. EHRs have allowed the sharing of medical records across many care settings and provide clinical support for the medical staff. Because of this, many do believe that EHRs are an asset in the care and payment. CMS, auditors, and lawmakers are concerned that the EHRs are causing the recent increase in higher levels being billed. What is the purpose of medical records? Medical records were once only used for the physician to write his or her findings and medical decision-making for a patient. Over the years, it has become much more than that. Now that the medical record is used for coding, billing, payment, compliance, and even for litigation. So are the patients sicker than before? CMS and others are concerned that the increase in the high levels is due to the improper use of EHRs. A recent study published by the AMA concluded that the Medicare patients are coming to the emergency departments with more complex conditions. The average severity of illness for a patient increased by 9% from 2006 to 2010. There are more and more patients on Medicare that are living longer, and they have at least 2 or more chronic conditions. This chart shows the emergency department visits. The visit type represented the 5th largest amount of Medicare payments for E&M services in 2010. Figure 3 shows the percentage of these services billed for each E&M code from 2001 to 2010 with the percentage difference between 2001 and 2010 above each code set of bars. In 10 years, physicians' billing of the highest level code, a 99285, rose 21%, increasing from 27 to 48%. During that time, physicians' billing of all other codes decreased. Physicians billed the lowest level code, 99281, less than 3% of the time. Audits are here to stay, and in fact, they may likely increase. If you're concerned or in need of any of the following, please contact me today. If you need help with documentation, if you feel your practice is an outlier, if you need help with audits and audit defense, physician education, or coding consulting. Thank you. If you have any questions, you can contact me at 513-281-4400, extension 211, or jdean@medicalreimbursementinc.com.